Hey everybody, it's Dr. Wood here again, and I'm going to be covering Chapter 2, Basics of Pharmacology. So first off, the question, what is a drug? Basically, it's any chemical that's going to be used for a therapeutic application, right? It's going to be used to help an individual, or in some cases you may find that it actually can harm an individual. We'll talk about some of those cases a little bit later on. Mainly, though, it's going to be altering any sort of biochemical function of the body itself, right? So it can lower blood pressure, it can make you fall asleep, it can do lots of different things in the body. So looking at the different drug components, you tend to find that there is one active ingredient in most drugs that is basically the pure undiluted form of the chemical. However, it's not the only thing that's usually included in those dosage forms. So if you think about a tablet, say a 500 milligram tablet of Tylenol, 500 milligrams does not make up that entire tablet. It actually weighs a lot more than that, and that's because of the inactive ingredients that are in there as well. Maybe things that are like vehicles that help to keep the drug stable. There could be things like preservatives, colorings, flavorings, all sorts of things. Those are inactive ingredients that are included within that product. Now, the ideal drug, if we were to ever have one, would have no adverse effects. We're outside of that. There's no drug like that. It would produce the same effect each time the same dose is given. So I could give it to a million different patients and I get the same response out of them each time. It would be easy to administer, it'd be inexpensive, and hopefully easy to pronounce and remember. We'll actually find that some medications, there's medical errors you can make because they are easily mistaken for other drugs, things that can sound very similar to one another. Things like hydroxyzine and hydralazine is a very common one that people will get mixed up. But again, most drugs do not fit at least one of these criteria, and sometimes they don't fit multiples of them. Again, as I mentioned, no drug is completely safe. Anything is potentially poison in a big enough dose. Water can be extremely deadly in the wrong dose. There's actually a case several years ago, if you guys are familiar with the Nintendo Wii. When it first came out, it was very difficult to find, and so they actually had a radio competition where it was called Hold Your Wii for a Wii, where basically people drank a ton of water, and whoever could hold their urine for the longest would win a Nintendo Wii. Well, what happened was, this one lady, she actually ended up drinking so much water that she diluted all the sodium in her body, leading to what's called hyponatremia, and actually developed seizures and died. Anything can be poisonous, right? Anything can have some degree of side effects or adverse effects there. And so the drugs we have on the market should be as safe as possible, right? And we want to find that, especially when we're giving them over a long period of time, hopefully they're not going to have any deleterious effects in that period there. And again, we should be aware of the effects of a drug to make sure that we're safely administering it. So we know which patients are good to receive certain drugs, maybe which patients should not receive it. And you'll learn about that as we get into more detail later on here. Now, a few basic categories here of pharmacology. There's the pharmacognosy, which is the origins of drugs, kind of where they come from. We'll talk a little bit about those, the different sources for medications there. Another big thing we'll talk about here as well is the pharmacokinetics, or basically how the drug gets processed by the body. Pharmacodynamics is going to be the actions of the drug on the body. So for instance, if we have something that blocks beta receptors, a beta blocker, that's the pharmacodynamic of the drug. The pharmacotherapeutics is actually the effects of the drug on the body. So if I give someone a beta blocker, it drops their blood pressure and their heart rate. That's the pharmacotherapeutics. And then the toxicology is the poisonous effects. If I give that patient the beta blocker and it gets their heart rate too low, or they get too low blood pressure, that can be very bad for the patient. So that's the toxicology of it. So historically, we'd find that most of our drugs actually came from pretty basic sources, right? So plants, animals, minerals, things like that. And then as time went on, we found better ways to form synthetic substances. And nowadays we actually have recombinant DNA technology that can help us to produce things like proteins that can be very useful for certain indications here. If you ever go watch TV and you find that there's a lot of drug commercials that come on, most of them are going to be for medications that have very long, difficult to pronounce names, but you'll notice a lot of them have MAB at the end of the name, so MAB. So infliximab, adalimumab, things like that. Those are actually monoclonal antibodies. Those are proteins that we produced via DNA technology to actually target certain things in the body. So looking at plant sources, again, I'm not going to have you memorize all of these, at least for testing purposes and things like that. But I just want to give you an idea of where we get some of these different substances that we use as medications here. So as an example, for instance, digoxin, which is a cardiac medication used for arrhythmias, is actually gained from the purple foxglove. Right, so it's a plant. You can see from that. Then Cristine's a cancer drug that we use pretty frequently in pediatrics, comes from the periwinkle. Morphine comes from the poppy plant, things like that. So there's a lot of plant sources that we have a lot of our medications come from. We also used to have minerals that would, and some of our minerals still are very useful as medications here. We actually used to give gold for certain rheumatologic conditions there. The patients had to have really good insurance though, because otherwise they couldn't afford it. I'm just kidding. It's actually super toxic, so we don't use it anymore. But certainly you can find a lot of products that contain calcium, like your Tums, magnesium, liquid magnesia. I mean, lots of things that include certain minerals. Animal sources, obviously cod liver oil comes from codfish, you know. This is actually an interesting one. So there's the urine of mares. So what is that? Basically, if you have pregnant mares, which are female horses, they produce a ton of estrogen that actually comes out into their urine. And so there is a product called Premarin, which stands for pregnant mare urine, that we use in order to replace estrogen in patients who undergo menopause. So if you ever want to kind of gross them out a little bit, if they're taking Premarin, tell them where that comes from. Nowadays, it's synthetically made, but again, this is where it used to come from, right? There are lots of inorganic and organic synthetic ways of making medications here. Again, the list would be quite extensive on this one, but things like oral contraceptives, penicillins, cephalosporins, anything is from that synthetic means nowadays. And then our recombinant DNA technology, this is where things like insulin are actually produced now. This is really cool because before we used to have to get insulin from bovine and porcine sources, so beef and pigs respectively, and so their insulin looked enough like human insulin that we could use that and inject it into people. But obviously that's problematic, right? Anytime you inject a foreign protein into someone, they can have an allergic reaction. You know, certain religions could not receive those animal products. It was a big deal. So now we have recombinant ways to produce things like insulin, right? We can produce things like erythropoietin, which stimulates our red blood cell production and things like that. So a lot of really cool ways we can make new drugs now. So moving into the kinetics for the drug, so the four main things that form the kinetics for a medication includes the absorption, the distribution, the metabolism, and the excretion, A, D, M, and E, right? And we'll go over these individually here, but basically this is what happens from the time you give a drug via whatever route it is, whether it's oral, intravenous, etc., to where it gets distributed to the body, how it gets broken down, and eventually eliminated from the body, right? Because you don't want any drug that sticks around forever, because again, that can lead to problems in terms of therapeutic effects and toxic effects potentially. So looking at absorption, these are kind of there's a lot of physical properties that will affect how well drugs get absorbed into the body. So as an example here, you can find that things like pH in the body can affect how well it gets absorbed, whether or not you've eaten a meal recently, how fat soluble the drug is or how lipophilic it is may affect it, time in the stomach, you know, inhalational factors, drug concentrations, all this can really affect how well a drug gets into the body itself. This is a really interesting one here. Incorrect administration is an important one. So for instance, if you were to say give a medication that's normally given orally, but you give it via a different route, you can actually find really increased absorption there. So as an example, I like to talk about ethanol. So ethanol, or ethyl alcohol, found in your alcoholic drinks, right? Normally when it gets absorbed through the stomach, because most people normally intake alcohol orally, a lot of it gets broken down in the stomach and also in the liver. So that way you only get like a fraction of it actually gets through into the body. It's called a bioavailability, and it has, you know, a lot of it gets broken down and before it ever reaches the circulation. Well, if you give it via a different route, you can actually find pretty much increased absorption of that drug, the alcohol, and people get way more intoxicated than they would otherwise. So examples of this would be things like rectal administration or intravaginal administration, right? There's been cases where high school females were found with tampons that have been soaked in vodka. They were found passed out in their desk in school because they did not recognize the fact that they get better absorption through that route. They got way more bang for their buck, so to speak, and they got really intoxicated and passed out, right? So again, the right route of administration is super, super important to make sure we're not causing potentially toxic effects for our patients there. Again, when you're talking about the absorption of medications here, when things are going through the GI tract, this is where we're talking about enteral administration, right? So enteral just means anything within the GI tract. So rectal administration, obviously going through the rectum. Nasogastric just basically means if you were to have a tube that, say, went from your nose down into your stomach, that'd be a little bit faster just because you're not having to swallow it and go through the esophagus and all of that. And then oral will be a little bit slower than that, right? Those are your enteral routes of administration. Parenteral basically means anything you're given via injection, right? So whether it's intravenous, intramuscular, subcutaneous, or intradermal, again, you can see the relative rates of absorption, how fast they are. And again, intravenous is the most fast because, again, it's going right into the veins, right into your circulation, right? So it's very, very quick versus, say, intradermal, again, going right into the skin would be a little, would be less fast than that, right? Would be a little slower. Percutaneous or mucosal basically means anything going across a mucous membrane or potentially through the skin, right? So inhaling certain drugs gets very fast absorption there versus sublingual, which means under the tongue, or transdermal through the skin, or just topical, meaning on top of the skin there. And so, as an example here, you find that certain drugs get absorbed very well from the lungs there, which is, if you're familiar with crack cocaine, which typically smoked, gets absorbed very, very quickly from the lungs and gets people. The effects are very, very intense, which is why crack cocaine tends to be more addictive than, say, other routes of administration for cocaine, right? Again, just little clinical examples of how these things actually come up in real practice, right, real life. Looking at this, at your oral preparations and how quickly they get absorbed, you tend to find that liquids tend to be absorbed much faster than your tablets and capsules. Syrups, elixirs, liquids, very fast absorption, versus down here when you have tablets that have to kind of get into solution, they have to dissolve, then they have to be absorbed. They tend to be a little bit slower in terms of their action. Obviously, things are time released, meaning they need to be released over the course of many hours, are going to be the slowest acting. So that's absorption. Moving into the actual distribution for these medications here, this is referring to where the drug goes once it's in the blood supply, right? So drugs, oftentimes they don't actually work in the blood itself. They have to get out to the tissues where they can have their mechanism of action, right? So if you're treating a seizure, obviously the seizure is happening in the brain. So if I'm giving a drug into the venous system, right, I'm giving a drug IV, I need it to partition from the blood and actually get out to the brain where it actually works. Okay, this is distribution, right? This is how the body likes to handle the drugs in terms of where it sends it out to, in terms of where it goes into the tissues there, okay? Some factors that can affect this can include how permeable the drug is to the capillaries, right? So how well it's able to cross those capillaries. Depends on the makeup of the drug. Sometimes they're just too large to get across some of these membranes here. Depends on the size of the person, the amount of drug given, and sometimes even things like proteins in the blood. So for instance, albumin sometimes likes to bind up drugs in the blood and prevent them from being distributed out to their tissues, right? So all of this has a big effect on how far out the drug gets into the tissues and how well it could potentially work. So some other barriers to drug distribution here. Certain areas of the body actually don't like to have drugs cross them. They like to be kind of protected. So as an example here, blood-brain barrier actually prevents most substances from crossing into the brain. Normally we want to keep the brain pretty well clear from other substances and toxins and things like that. But certain fat-soluble substances are able to cross over pretty easily, right? So some drugs that we want to work in the brain will actually make them really fat-soluble so that way they can cross over and work even better, okay? Placental barrier normally is really handy for helping to prevent a fetal exposure of medications, but certain things can cross over no problem. For example, alcohol can cross over, which is why you see things like fetal alcohol syndrome when mothers are consuming alcohol during pregnancy. Okay. And so again, you'll find certain drugs like to go to certain tissues. For example, digoxin, which I mentioned before, is an antiarrhythmic, really loves to bind to the heart, which is good because that's where it works, right? So sometimes it's pretty selective there. Now, once a drug has been absorbed, it's been distributed to the body, it needs to be broken down, it needs to be getting rid of. And so this is where metabolism occurs here. There's a few sites where this can happen, but the main place is going to be the liver, right? You're going to have different enzymes within the liver that will break down drugs to make them more water soluble, which gets them ready for elimination out of the body here. And again, this is a big deal because if your liver is not functioning very well, then you're not going to metabolize drugs very well, and that can lead to some big problems. So again, the condition of the liver is a big deal. If you have someone who's a chronic alcoholic, their liver may not function that well. If they're cirrhotic and it's a lot of scar tissue in that liver there. The other big thing to note here as well, that first pass effect. That's that thing I was talking about when you have someone who consumes alcohol from the oral route. Part of that gets broken down by the liver before it reaches that blood supply. That's the first pass effect, right? It limits how well certain drugs can actually be absorbed into the body. And in fact, some drugs can't be given orally because they have such high first pass effect. So much of it gets broken down, none of it ever gets absorbed, okay? Other things like the age of the patient can be a factor here. And ultimately what this all will determine is what the half-life of the drug is. Half-life means how long it takes to get rid of 50% of that drug, okay? Some drugs have really short half-lives, like 10 seconds. Some drugs have half-lives of, say, 50 to 100 days. Really, it's going to be drug dependent, and oftentimes it can be dependent on that condition of the liver, as we mentioned. And finally, we have excretion or elimination. So once the drug has been broken down into its inactive components, it will then be eliminated from the body. The most common place this is going to be through the kidneys. It'll get filtered through the kidneys, or the blood gets filtered, and that will then be eliminated in the urine. Okay. Sometimes things will be sent out through defecation, right? So it'll be eliminated into the GI tract and then defecated out. Sometimes you can actually have perspiration, you can sweat out certain substances, or you can actually breathe out certain substances. If you think about, again, alcohol, which I know I use this as a big example here, you ever think about a breathalyzer? It's detecting your the amount of alcohols in your respirations there, right? So again, certain substances can be eliminated that way as well. So a lot of factors can affect this. Mainly one of the big things is going to be how well the organs that are excreting the substances are actually work. And so this means how good your kidney function is in a lot of cases there. And so this is really, really important, because if we have a drug that is renally eliminated and a patient's kidney function goes down and we don't go back and readdress the dose of that drug, they can have some significant toxicity there. So we really want to be careful with that. Another big thing to consider as well, the milk glands can actually pick up some medications there. Again, this is another reason why certain nursing mothers should not be consuming certain substances, and alcohol is another big one, because that can actually pass into the breast milk and then be passed on to the feet, or to the actual baby. So again, this is why you should always have nursing mothers check out with the provider prior to taking any medication to make sure it's not going to affect the baby. So that's a review of the kinetics there, right? So again, how we're administering the drug, how it gets absorbed from that route, where it gets distributed to in the body, how it gets broken down, and then eventually eliminated from the body finally. Okay, so those are the 5 key components here, and we'll get into more details on these when we talk about specifics of drug administration. We talk about specific substances, we'll get into these other things. So then moving on, the pharmacodynamics of the drug, or actually what the drug actions are in the body. This is where we talk about the mechanism of action of a drug, right? So again, what is the drug actually doing to the body itself? Now again, most of the time these substances are not giving the organ or tissues new functions. Most of the time it's either just slowing down a process or speeding up a process here. Or in some cases, may actually be protecting the body from foreign substances from interacting with it. So when we talk about site of action, this can mean a few different things. So some drugs work very locally, right? So the drug action is limited to wherever you actually administered it. So imagine you were to cut yourself. Say you were trying to cook some dinner, you cut yourself with a knife, and then you have to go to the ER to have that laceration sutured up. They can apply local anesthetic that only works to numb up the area where the laceration occurred. It doesn't make your whole body numb, just makes where you put that drug at numb, right? That's the local action there. Systemic action would be if you were to say have a lot of pain associated with that laceration, and they give you a drug intravenously for treat that pain, and it affected the entire body. That's systemic action. Okay, these are different depending on the drug you're dealing with. Some drugs have only local actions. Some drugs only have systemic actions depending on how they're given here. Right. And again, this remote action is when the drug action is going to be at a site distant from where the actual drug was administered. So as an example, I could apply a pain medication to the skin. Doesn't just work at the skin, actually can work systemically from there, right? So again, that's another thing. This is less common, you're going to find. Most often, most of the drugs we give will have systemic actions. Now, when you're looking at the pharmacodynamics and actual drug actions in the body, there's kind of 4 major effects you can see with this. So to depress something would basically mean to lessen the body activity here, right? So say, for instance, I'm having too high of a blood pressure. I can lower that blood pressure. It's kind of sort of a depression sort of effect. I can have a stimulating sort of effect here. So imagine taking an ADHD medication to increase your focus. That's a stimulating sort of effect there. It's increasing body activity of a certain system. Irritations, where we're going to be producing areas of inflammation. It's not a super common one, but it's something you can see in some cases. And then demulcents here is going to be this producing a soothing sort of effect. So maybe you have an anti-inflammatory, they'll have a demulcent sort of effect. And so when you're actually looking at the pharmacotherapeutic, so we know the dynamics of a drug, how it's actually working in the body. Well, how do we use it? What is it being used for, right? So an example, there's 5 different cases where you'd commonly see medications prescribed. It could be for a therapeutic purpose, right? So we are maybe trying to maintain homeostasis, right? So I have a patient who has a low blood pressure, so I give a medication to increase that blood pressure. Right? It's therapeutic, fixing a problem. Could be diagnostic, so I can use it in the aiding of diagnosing a disease. So as an example, I could use allergen skin testing to see if a patient has an allergy to, say, pet dander, right? There's destructive effects where I can actually go and destroy cells and tissues, and I will tell you most of the time we don't like to destroy our patient's cells and tissues, but this may be really useful in cases of cancer, right? Destroy cancer cells or destroy bacterial cells that are infecting the body, okay? Sometimes we're doing it for pharmacodynamic purposes where we can alter the normal body function. Say, for instance, a patient is hypothyroid, we can give them a thyroid replacement to kind of restore the normal body function. And then prophylactic, meaning we're trying to prevent a disease from occurring in the first place. And again, looking at the effects of the drugs, there are desired effects, which is kind of the intended response that we're looking for. So if I give you medication to lower blood pressure and the blood pressure comes down, that's desired. But side effects are going to be the mild, annoying, or maybe undesirable responses. So if I give you that same blood pressure lowering medication, but now you have an annoying cough all the time, that would be considered a side effect. And again, all drugs taken in excess can act as a poison there, right? I mentioned even water, even oxygen can all be poisonous potentially, but the dose is really what makes the poison here, okay? So again, it's important to know what a normal dose for medication is that you work with, so that way you can kind of catch if something weird's going on and maybe the patient's getting way too much. And I'll tell you, there are certain antidotes you can give to try to reverse the effects of a poison, but for the most part, we have very few antidotes given the number of drugs we have to administer to patients. So this is why you want to prevent the need for antidotes in the first place by making sure you're administering the correct dose for a given patient. Now again, we're looking at unwanted effects of the drugs here. Usually adverse reactions tend to be kind of a step above kind of where the side effects are. Side effects I mentioned could be like an annoying cough. The adverse reactions are really going to be a little bit more unpredictable, more undesirable, could really lead to more patient harm. And this can include things like maybe an allergic reaction, right? So a patient develops anaphylaxis after receiving just one dose of a drug, right? Give an example of some things that can happen with anaphylaxis, and this is why it's so important to make sure when patients have allergies, you want to make sure you capture that sort of thing. So if they have a penicillin allergy, you want to make sure you're aware of that so you don't accidentally give them a penicillin, right? So symptoms like that can include things like hives, reddened skin. The big things you worry about are things like bronchospasm, where they can actually have the bronchial smooth muscle constrict, so they can't breathe very well, they can't oxygenate very well. They can get dyspneic, they can get vascular collapse, loss of consciousness, arrhythmias, and then death, right? So these are big things we want to avoid. And again, if you can catch it by knowing things like the patient's allergies beforehand, that's really helpful. And again, sometimes you can ask questions. If you think someone's having an adverse effect to a drug, what kind of questions can you ask about that? So ask about timing of things. Was the medication introduced and then they developed the side effect? Maybe they stopped taking the med and then they restarted it and the same effects continued. Things like that you can ask and try to determine, hey, is this really a side effect or is this something else that's going on with the patient there? And again, anytime you're worried about drug interactions, make sure you keep a constant updated list of your medications that your patient's taking there. Make sure it's updated. A lot of times you're going to find that people will see multiple providers. So they have different specialists that are all prescribing different drugs, and they may not be communicating with one another. So you want to be careful with that and make sure that you're kind of getting all the information you need to make sure you're not going to be running into another drug interaction. So diving a little bit more into how the actual drugs are working at their receptor sites. So really, anytime a drug molecule is traveling within the blood, they're not working until they get to their appropriate receptor site and they actually work. And I'll show you some pictures of what this looks like. But basically, the drug has to be able to fit into that receptor site in order to have any sort of biological effect, right? So again, it's a lock and key sort of mechanism that we're talking about here. Two really important terms that I'll make note of here. If a drug binds to a receptor and activates it, it's called an agonist, okay? This is a receptor activator, but agonist is a common term here. So if you ever hear about a beta receptor agonist, that means it's binding to and activating beta receptors. Albuterol is a really good example of this. That's what your asthma inhalers that you normally see. Those are albuterol. It's a beta 2 receptor agonist. The flip side of an agonist would be an antagonist, meaning that it's something that binds to the receptor, but it blocks it, prevents anything from coming and activating it. Okay, so presumably there's a beta receptor agonist, there's something like a beta receptor antagonist, or as we normally call it, a beta blocker. And atenolol would be an example of this common medication used for hypertension or for fast heart rhythms, things like that. And so to look here, you can see this is what the drug would normally look like and see how it fits perfectly into the receptor itself, right? So again, this complex here, meaning it's going to have its physiologic effect. It's going to activate it and cause whatever effect that it would normally cause. This would be an example of an antagonist that fits in here but doesn't actually activate the receptor itself. So because of that, you're going to be finding that it would prevent whatever actions that would normally the drug would cause, and this is your antagonist sort of effect here. Sometimes you can actually have a drug that will partially activate it, and this is called a partial agonist. I wouldn't worry too much about this right now, but we may talk about these in more detail later on as class goes on. But the big ones to remember are the agonist and the antagonist. These are kind of flip sides of the same coin here. So, as I mentioned, any agonist is going to bind to that receptor. It's going to mimic the normal body functions when something would normally bind there. And again, it may be competing with other drugs potentially, as the case may be. The antagonist, though, would bind to that receptor, and it kind of prevents anything else from coming in and activating it, right? So again, that's why it's a beta blocker, because it prevents anything from activating that beta receptor there, right? So you kind of get the opposite effect of what you would expect to see if an agonist were to have bound to that receptor there. To give an example here, if I give an agonist, a beta agonist, it's going to cause your heart rate to go up, but if I give you a beta blocker, that causes your heart rate to go down, right? Now, when you're actually mixing and matching drugs together, you may find drugs may have some synergy, right? They may actually potentiate the effects of other drugs. In some cases, you may have an additive effect where you get the summation sort of effect here. We're adding, say, 2 plus 2, you get 4, right? So again, the drugs are working just as well as they would normally, but you put them together and they add up, right? Sometimes you get even better synergy there, and so you may find that one drug is going to augment the effects of the other to make it that much more effective, and they can really pack way more of a wallop there. So this is a synergistic effect where maybe 2 plus 2 equals 5, or even more in some cases here, right? So another case here, another term is potentiation. Again, this is where one drug maybe prolongs or augments the effects of another drug. I'll give you a good example of this would be if someone's drinking alcohol and they take it along with a drug like Xanax, anti-anxiety drug Xanax, they can actually really potentiate the effects of and make it so that the patient gets way more sedate and it lasts a lot longer. I mean, they could be at risk for things like respiratory depression and death. Okay. Tolerance is a term that where we see with long-term use of a drug, the effects of it tends to wear off, right? Or it tends to lessen over time because the body kind of gets used to having that drug around. This happens a lot with pain medications. Patients taking, say, morphine for long term, they may find that the same dose really isn't working for them anymore because their body is used to having that drug around. So in those cases, what do we do to get around it? Well, you have to increase the dose. And so you can find patients who are long-term opioids are on really, really high doses that are safe for them. If you were to give it to someone else, it could be really potentially deadly. So that's something we want to be careful of there. And then finally, accumulation sort of effect or accumulation. This is where a drug does not get eliminated from the body as it should, and as it builds up and can lead to more toxicity. This is usually when you have organ function impairment, so the renal function's gone down, liver function's gone down. This is where you can see accumulation of that drug. Now, you may find that foods can actually interact with your medications to either cause therapeutic failures or it could actually induce toxic effects depending on the case there. Say, for instance, you were to have food on the stomach and it may either increase absorption or it can actually decrease absorption, as the case may be here. In fact, some medications may not even be able to be taken because they bind up with certain foods and they will not be absorbed. A really good example of this would be, for instance, if you were to take the drug Cipro, which is an antibiotic. If you take that with milk, the calcium in the milk actually binds it up and prevents it from ever being absorbed, right? So the drug doesn't work. They don't clear their infection. In some cases, you may find that certain medications have to be taken with food just to prevent gastric irritation, right? So things like non-steroidal anti-inflammatory drugs or NSAIDs like ibuprofen need to be taken with food in some cases to prevent irritation for certain patients who have that. Sometimes you can have drug-disease state interactions here. So this is an example where one drug actually is harmful to another person's disease state. So let's say, for instance, we have someone who we have to give a steroid to, right? So we give an anti-inflammatory steroid like prednisone or dexamethasone, and that raises their blood sugar. Well, who might that be bad for? It's bad for diabetic patients, right, who are already having issues with their sugar in the first place. This is where a drug is actually being antagonistic to another disease state for that patient there. And again, interactions are always going to be much more commonly in the elderly because they have more diseases and they thus take more medications. You can find some elderly patients who are taking 12, 15, 20 medications, all for, say 8 different disease states. It's really important to remember that. And again, this is why you need to make sure you get up-to-date medication lists for your patients, especially if they're seeing multiple providers. So that's it for chapter 2. If you have any questions, please let me know, and I'll talk to you next time. Thanks a lot. Bye.